episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome everybody again to another episode of our show with another truly fascinating individuals helping to create a better tomorrow for all of us. And today we are going to journey back into the theme of diabetes, that scourge, that group of metabolic and endocrinological pathologies that affects over 300 million patients around the world today. World Health Organization estimates 500 million by the middle of the century, with global economic costs of medical costs and reduced productivity somewhere around $3 trillion. And as such, we are honored to be joined by Dr. George Gittes, who is a chief in the Division of Pediatric Surgery and the Benjamin R. Fisher Chair in Pediatric Surgery at the University of Pittsburgh Medical Center at Children's Hospital of Pittsburgh. Dr. Gittes is also the co-scientific director of the Richard King Mellon Foundation Institute for Pediatric Research, director of surgical research, and professor of surgery and pediatrics. He joined UPMC back in 2005. He served as surgeon-in-chief and chief of the Division of Pediatric General and Thoracic Surgery, which is one of the busiest pediatric surgical programs in the United States, and one of the only only two level 1 regional research pediatric trauma centers in Pennsylvania. In 2018, he was appointed director of the Mellon Foundation Institute and co-scientific director of UPMC Children's Hospital. He also assumed the title of surgeon-in-chief emeritus. Dr. Gittes is a nationally recognized pediatric surgeon, well-established basic scientist as well. And at the Mellon Institute, he leads their initiatives to incubate research projects that pose very high-risk, high-impact investigations, lead to paradigm shifts in pediatric medicine. There, he and his team have been performing fascinating studies using gene therapies and technologies for cellular transdifferentiation to potentially treat and reverse diabetes, leading to potential game changers there. Dr. Gittes came to Pittsburgh from Children's Mercy Hospital and the University of Missouri Kansas City School Hospital and the University of Missouri Kansas City School of Medicine, where he held the Thomas Holder Keith Ashcraft Chair in Pediatric Surgical Research. He's been actively involved in mentoring the next generation of scientific researchers, has his MD from Harvard Medical School, a surgical residency at UCSF, as well as a research fellowship in Hormone Research Institute and Gastrointestinal Research Laboratories, also at UCSF. Has a large array of awards and honors and hundreds of publications. We won't go into it right now, but Dr. Gittes, thank you for taking the time out of your schedule to come talk to us for a little bit.
My pleasure, Ira. And my gosh, you've really done your homework. I'm very impressed.
I tried to.
Okay, good.
Dr. Gittes, before we go into some of your work, I'd love to, if just for a couple of minutes, you took the time to introduce yourself, just talk a little bit about sort of, where you grow up, when you got interested in medicine, and if you can sort of recount this fascinating anecdote that I read about how when you were entering medical school, you decided to write a bunch of letters to researchers at the time, and of all people, Judah Folkman of angiogenesis fame got back to you,
Yes.
sort of lay the groundwork for everything
Right.
that came after.
Well, right. So I grew up down in La Jolla, suburb of San Diego, 2 blocks from the beach. So I was kind of a surfer boy, body surfer, and that was great. And then moved to Cambridge, Massachusetts for undergrad at Harvard, which was a bit of a shock, but it was fun. I loved it. But then I had an unusual opportunity because when I was accepted to Harvard Medical School, I had the opportunity to then sort of be on site in preparation for that because I was there. And I, like you said, over that, I wanted to start, I'd done research all through, since I was 13. I was doing microsurgery on rats when I was 13 years old at Harvard Medical School lab over the summer. So it's a little bit of a freak. But or as I tell people, my dad was an academic surgeon, was brainwashing me. But so I took that opportunity. I said, well, I want to hit the ground running at Harvard Med School. So I said in the spring of that year, 1983, I sent out 13 letters to a bunch of professors at Harvard. They had this booklet you could look at and figure out what people were doing. And there's some of them I was just most of these big shot professors ignored me because I was a college student. It's not surprising. A few said, "Sure, you can work with this postdoc over here, or whatever. Get away from me." But this one guy, Judah Folkman, was amazing. And I think he sort of said, "Well, who's this college student who's like so gung ho? He's already writing letters. That's unheard of." So I think he saw that, I think, and said, "Okay, let's." He spent an hour with me, toured me the lab, and I was like, "Okay, this is a no-brainer. I'm gonna work with this guy." And yeah, and he is, as you alluded to, he's the father of tumor angiogenesis. How how the cancers can only grow if they attract new blood vessels that they need for their oxygen to be able to get bigger. And that was his kind of passion. And unfortunately, he passed away about a year before I came to Pittsburgh. But anyway, but he was a pediatric surgeon. And at the time, I really didn't know what that was. I thought maybe that was like a pediatrician who also does some surgery or something. I didn't really know what it was. Turns out pediatric surgery is a pretty intensive field. It's probably the most competitive specialty to get into in all of medicine. It's super competitive. I mean, I feel bad for the people now that are trying to get in. It's just like, it's their passion and they just can't do it because they can't get into a fellowship. But I did, and I loved it. But his role as a mentor, as a surgeon scientist, that's shaped me. But the problem I've dealt with my whole career is the fact that, not my whole career, but for most of my post-training career, is that I got stuck on diabetes. And the problem is it's not really a surgical disease. So I've never really had this nice syncing of what I do clinically with what my research is related to. And at first that was really hard because I wasn't like networking with the endocrinologists and all that. I was at the surgery meetings and they're like, what kind of research are you doing again? Why are you doing that? So it was a little hard. But then over time, I get involved with the NIH and study sections and whatnot. And as my career was getting better, I get more connected, and it hasn't been a problem for the last 15 years probably. But yeah, so what happened was, so the pancreas is where the insulin cells are. But I wasn't interested in that because the pancreas is also a very much of a surgical organ. You operate on it for pancreatic cancer and other blockages and things, but not for diabetes. I was a pediatric, I was interested in pediatrics. So I was studying how the pancreas forms to better understand that. And after about 6 months, it became clear to me that you forget about you need to focus on the insulin and the diabetes part of it, even though it has nothing to do with surgery, because that's where all the action is. And that's what's important. And funding, from funding agencies, that's where we're going to get the funding is diabetes. So I kind of diverted, and it's been ever since then. So that was back in 1989 or 90 or something. So it's been a kind of a 30-year road looking at that. And then that just kept evolving, where I was studying only how the development of the pancreas, the embryology, and then over the last maybe 12 years, it's become more of a focus on how the insulin cells grow, with the idea more towards clinical translation and treating people by getting them new cells. And then we had this whole serendipitous finding that led to this gene therapy thing that you alluded to in the intro, that has been more over the last 6-7 years.
Excellent. And yeah, when I look at the sort of the field of regenerative medicine, stem cells, and so forth, when we bring up this topic of transdifferentiation, which you are leading, this research in, I mean, it is clearly the very, I'll say, the bleeding edge of this domain. And here we have, we're made up of however many 200 cell lineages, and we all have the same genome. And with certain tweaking, you have the ability to, whether it's a spinal cord cell or a heart or whatever, to move that cell between fates. You published in 2018 this paper, Endogenous Reprogramming of Alpha Cells into Beta Cells Induced by Viral Gene Therapy, Reversing Autoimmune Diabetes. Used a variety of transcription factors, looking at how you could take an alpha cell, which normally makes glucagon, and turn it into a beta cell, which makes insulin. Talk a little bit about this research, if you would, and what it was like sort of creating this project, which is really, as I say, on the bleeding edge of cellular differentiation, redifferentiation research.
Yeah, I'll reiterate, but you really have done your homework. That's pretty impressive, Ira. But anyway, what I would say is, that for many years, the stem cells was considered all the rage.
Yep.
And, if something isn't, after 20 years, which is what it's been at least, if something's not really panning out, it's not developing, it's probably not going to work. And there's just too many problems. I'm biased because I'm not doing stem cells, but I think there's just so many problems with stem cells in terms of their truth. Are they truly functioning? Do they make cancers? All these things. Anyway, so because of all that, kind of issues and reticence on part of the public, I guess, to accept it, gene therapy not gene therapy, but transdifferentiation of existing cells forming cells you want to have is probably more realistic. And I must say we benefited from the stem cell field because they figured out these things called inducible stem cells, that whereby manipulating them, massaging their gene expression patterns, they could turn them into cells they wanted to. Well, that's still stem cells, though, from the outside the body that you're giving to them, as opposed to, hey, why don't we just do that on cells that are already in the body? We don't have to worry about rejection. We don't have to worry about cancers. And that's been kind of a theme that's progressed. And one thing that for the most part, not always, but a lot of times gene therapy, which means putting genes into cells and making them do something that they hadn't been doing before, that is viral typically. Viruses are really good at getting into cells and putting the genes in there. That's what they do. Yep. So anyway, so we had developed a system in the pancreas to infuse virus, not for the purpose of any kind of treatment, but because we wanted to tag cells and figure out, okay, who's turning into what by using little fluorescent colored tags and saying, well, who turns into a beta cell or an insulin cell in what situation? And that's obviously an interesting question. It has potential implications in terms of therapy. But then on a lark, because of some other publications that had come out over the recent period, we put some of these, what you as you mentioned, transcription factors or genes that control how other genes are produced. We put them into these viruses and said, what the heck? Let's just put this in the pancreas. Because one of the things about my situation is that, yes, diabetes is not a surgical problem, but my surgical background really helps developing a lot of these techniques. So we developed this technique for infusion into the pancreas. That's a surgical procedure. So we started in mice, and have since gone to monkeys, but it's a fairly elaborate surgical thing. So I guess I have a little bit of an advantage in terms of I can do these things, on a whim, because you can sort of figure out how to do it surgically. And I'm a pediatric surgeon, so I'm used to operating on little tiny, 500 gram preemies or stuff like that. So anyway, in doing so, we figured out this technique, and we tried these transcription factors, and sure enough, we were able to turn the alpha cells that you mentioned that make another hormone, glucagon, has kind of the opposing effect to insulin. It raises your blood sugar. But we were also able to show that not only do they turn into insulin cells quite robustly, actually, but the shocker was when we said, well, what the heck? Let's just try this in a model of juvenile diabetes where they react to their own cells. And logic would say, well, that's stupid, because you're going to make new insulin cells, and just like the other insulin cells, they're just going to get killed by the immune system. And the amazing thing was they weren't, at least not for a long, long time. And we dug down into that and figured out that it was because they're not perfect insulin cells. They're a little off. Okay. And our suspicion is that they're off in a way where the immune system doesn't recognize them, but they function very, very nicely. So that's been kind of an exciting thing. It's also, but you alluded to potentially 500 million people having diabetes. Most of those are not autoimmune. They're type 2, where their body has developed a resistance to insulin. So their beta cells, and a lot of us have that. Like I may have that, I don't know, but my insulin cells are able to overcome that and make enough insulin that it's not a problem. But the people who get this type 2 diabetes, their insulin cells kind of poop out. It's called the burned out pancreas, and they need insulin. So they would definitely benefit from this as well. And we've shown that. So we're pretty optimistic that both those avenues will be fruitful in the near future. And we're well into these monkey studies. The monkeys have to have, in order to do this infusion of virus into their pancreas, the monkeys are small, and we need to do surgery on them to get in there. So it's a pretty big operation on a monkey that I do. And, it took us 4 years to figure out some of the nuances, because their anatomy is not, I know the anatomy of the humans very well, but I had no idea about monkeys. And there are some very subtle but critical differences in their anatomy that took us several years to figure out. So that was a challenge, but we've gotten there, and we're getting pretty good results with monkeys now with this gene therapy. So we're pretty optimistic. And I think because of that, this technology got licensed by this Texas-based gene therapy company called Genprex, and they're all excited about it. And, they keep calling me and saying, "When are we going to get started?" Like, slow down. So we're getting it up.
It's great. It's great to see that technology transfer happening, because it's important. It's what gets it to everybody. So that's exciting. Along those lines, I think offline I mentioned I had talked maybe about last year or so to Denise Faustman's group up at Harvard, who was doing some things on the immune front, and I noticed also in your portfolio you had a very interesting paper was on activated macrophages in creating a better microenvironment for regeneration. And I really found it interesting because, we think so much about the immune system, especially in the middle of this pandemic, as taking care of infections. But the immune system, interestingly, has, depending on how you modulate it, pro or anti-regenerative effects. Can you talk a little bit about some of what you're studying there?
Okay, so it's a really amazing thing how I would say 15 years ago, if you started talking about these immune cells and how they are affecting, I mean, obviously the autoimmune cells are bad and they attack the cells and they kill them off in juvenile diabetes. But the idea that these cells have such an important role in regeneration or not, and people would kind of poo-poo that and say, "Oh, that's come on."
Yeah.
But it's real for sure. And as you alluded to, other groups around the country and the world are really starting to get into that. We did, and we have recent data that's now we have submitted it to be published, so it's pretty far along, showing how through an additional, so we do this infusion, through the virus to change these one cell into the insulin cells.
Mm-hmm.
But if we couple that infusion with a second, not a second infusion, but a mixture with another virus that affects how these immune cells, the so-called resident macrophages, how they behave, it turns out they're a critical component to whether or not the autoimmune system is reacting to the insulin cells or not. And it's kind of a nice double sort of synergistic hit we can do to not only induce this transdifferentiation you talked about, but also to locally suppress. Because one of the problems with, autoimmunity is that it's very hard to suppress it.
Yeah.
Like we talk about suppressing immune reaction to like a transplant.
Mm-hmm.
That's the problem, like islet transplants, for example. Well, you have to suppress the immunity that would normally reject the islets because it's a transplant, but that doesn't necessarily prevent the autoimmune, right? So if you're giving the islets for autoimmune diabetes, you're trying to give them new islets. So, but it's a foreign islet, so you got to suppress their transplant rejection. But they've still got autoimmunity. It's going to say, hey, wait, that's an insulin cell. I'm going to kill it. So you got to suppress. But they're totally different. So the immunosuppression you've got to do for type 1 with an islet transplant is really aggressive and then not good. Mm-hmm. So the fact that we can do this infusion locally and inhibit the process on only a local scale and not suppressing the whole immune system throughout the body is a big advantage.
Excellent. One other area that you've worked in, which is extremely hot nowadays, not just in metabolic, but many other disorders, is this topic of autophagy, this process of sort of cellular eating where the body removes unnecessary or dysfunctional cells. You also published a paper, Cellular Autophagy in Alpha Cells Plays a Role in Maintenance of Isolate Architecture. I apologize before when I did my intro with the 300 million, but obviously this is something that applies to potentially that 300 million when we have to talk about type 2 diabetes, weight, and the fact that, it's a disease that has, as you're pointing out, pancreas, but also the liver and the muscle and various, it's a very complex disorder. Talk a little bit autophagy, if you would, and some of the things you're learning there, not just for, I guess, rebuilding the structure of a pancreas, but in other areas of the diabetes domain that you're researching.
Well, so autophagy is what it is it's not necessarily the whole cell going away, but it's the cell getting rid of bad parts and eating those things. That's the phagy part of autophagy. Mm-hmm. So self-eating is what autophagy is. But but by eating those parts, it generates potential sources of energy for its other functions of the cell to work better. And diabetes is a highly complex metabolic disease. And when you're talking about metabolic, you start to get into individual cells' ability to function properly. And one of the things that is a problem in diabetes is that the beta cell, the insulin cell, is what we call a highly professional cell. So it's super busy making insulin all the time. And in fact, it's probably the most metabolically active cell in the body. But that puts it at risk for what's called endoplasmic reticular stress, or a stress from having to be overworked to make insulin or make protein. And then when you drive that further with some sort of insulin resistance, or for some of these cells are being killed, because some of the insulin cells, a lot of its friends are being killed, that means it has to work harder to keep up. So it gets more stress. And because it's already such a professionally synthetic cell, it's very easy to push it over the top. And the other thing that can be a problem is if the alpha cell, those glucagon cells, so what glucagon does, it raises your blood sugar, and that means more work for the insulin cell. So there's a lot of people who feel that diabetes is just as much a disease of the alpha cell or glucagon cell as it is of the insulin or beta cell, one underfunctioning and one overfunctioning. And so this autophagy business is a way that the alpha cells maintain a high level of function that can be problematic for beta cells, or if it's autophagy to the point of them suppressing their function, that could be good. So it's just, and we're looking at, we have a lot of work going on related to these glucagon cells and what they do and how they function. And especially what the interaction is inside this ball of cells in the pancreas called an islet, a little island of endocrine cells amongst an ocean of non-endocrine cells, these digestive cells that most of the function of the pancreas. That's the kind of stuff that I was working on early on before I got into diabetes, was that other part. It's called the 99%, but it's not nearly as important as the 1% that's the endocrine. But it's sort of ironic. And it's actually one of the things that attracted me to the pancreas in research, was this kind of weird dichotomy of existence where you've got these two totally different things immersed in one organ. It's kind of cool. But anyway, so anyway, this what's going on between those two cell types and how they interact and whether it's autophagy or just general paracrine, meaning secreting hormones locally to affect each other locally, as opposed to endocrine, which means going throughout the whole body, or autocrine, which means secreted to affect your own cell. These are all different. The paracrine process in the islet, we think, is very important between these glucagon cells and the insulin beta cells.
It's a fascinating microenvironment of stuff. It really is.
Yeah.
One other thing you mentioned at the beginning, and I don't know how much time you spend on it now, but you brought up the theme of pancreatic cancer, and as a surgeon, you have the responsibility for cutting and removing and so forth. I don't know how much time you focus on pancreatic cancer nowadays, but can you give us a couple of minutes of your insight? I mean, we see obviously the Alex Trebeks and the Patrick Swayzes in the news. The mortality on this stuff is worse than melanoma, and some.
It's probably the worst cancer there is.
Has there been any insight on why we're seeing such? I don't know if the rate's been going up with pancreatic cancer, but it seems to be more prevalent, let's say, than I remember hanging out in sort of oncology areas in my past careers. Anything you could share with us on the pancreatic cancer front?
Well, yeah, I mean, a lot, but I'm a pediatric surgeon, and pancreatic cancer is very rare in children.
Sure, I understand.
But it is a huge problem, and one of the things the reason we're working on it, I've got a recent a nice NIH grant related to not only pancreatic cancer, but some other aspects. So I told you a little bit about how it's good to be a surgeon scientist.
Yeah. I'm
going to tell you another little anecdotal story, which I love to tell, about how again it's helpful. So I told you about how we worked out this virus system, infusion into the pancreas.
Yep.
Okay, that was great. We tag the cells with colors and see where they're going and everything. But in some mice have special genes in them, which are where genetic changes occur in the mouse only if you give the mouse the estrogen-like cancer drug tamoxifen. Okay. So we give the mice tamoxifen, we turn on these genes or whatever, So these are all in the pancreas. But one of the guys in the lab said, hey, wait a minute. We have this infusion system we can do. Why don't I infuse high-dose tamoxifen right into the pancreas? It'll really turn these genes on really well. And so the only problem here, Ira, is the solution that you use to dissolve this tamoxifen for this kind of usage is 100% ethanol.
Ooh.
Yeah. That's pretty nasty stuff. It's like what we pickle things with. Anyway, so he comes to me and says, yeah, I did this 100% ethanol. And I'm like, what are you talking about? You can't do that. They're just going to die. And he goes, no, they're fine. I'm like, what are you talking about? So sure enough, I immediately go with him to look at these mice, and they're running around the cage. They're happy, and they are fine, except they're not perfect, right? So I sacrifice one of the mice, open them up, and there's the pancreas is gone, except all these islets I was talking about. They're all perfectly preserved, all of them. Wow. Yeah, this actually was just published, Ira, literally. It actually, the formal pub is not even out yet. It's just the pre-pub is out. That's how new this is.
Okay.
The formal pub, I think, is coming out in about 2 weeks in a good journal, a journal of clinical investigation. Anyway, so and he's like, the postdoc is like, oh gosh, I guess it didn't work. I'm like, no. You may have just cured chronic pancreatitis, which is this horrible disease where people suffer from pain all the time. And we try to get rid of the pancreas and do this, but then they all get diabetes. It's just terrible. And the other. So that's in the works now. We've done it in monkeys. We're doing cadaveric studies to make sure it works technically in humans. But we're ready to go on that. But anyway, so but the other kind of cool thing about it is, and well, people with chronic pancreatitis have about a 14-fold risk. There's a lot of these people. There's 250,000 people in the country that have it, but they all have a super high risk of pancreatic cancer. And we have shown preliminarily that if you do this in mice that are going to get cancer, they don't get it. In fact, if they have cancer and we infuse this, the cancer isn't. There's no way we think we're going to cure this pancreatic cancer. But one thing people don't realize, most people that get pancreatic cancer they're going to die for all likelihood. It's a very high, the overall survival is like 2%. But most of them undergo this big operation, which is very morbid. It disturbs their whole anatomy. They're sick, really sick afterwards. And we're very hopeful that this procedure will, and the reason they have the operation is because they have symptoms. They have pain, it's blocking their intestine, things like that. They're just miserable. And to be able to do something non-surgical, I mentioned to you, I had to do a surgery in the monkeys. That's because they're small. In humans, you can go through the mouth and with a scope and find this opening and infuse into it. It's pretty straightforward. They do it all the time for other reasons, nothing like this. But yeah, so that's our hope, is that this would be something that would obviate the need for this awful, huge operation. Now, my pancreatic surgeon friends may not be that happy with me, but it's real. I mean, it's a real possibility. But for the chronic pancreatitis, it's happening.
Interesting.
Those patients are absolutely miserable.
Fascinating.
And plus they get diabetes.
Sure.
Because their insulin cells are kind of like poor innocent bystanders sitting there, where all that 99% is like getting inflamed and angry and generating all these bad toxins that then kill off all their insulin cells as bystanders. And we showed clearly that does not happen if we kind of block this vicious cycle by doing this infusion. Turns out we don't need ethanol, which is good, because probably 90% of patients that have chronic pancreatitis is from alcohol. So there's really that's kind of tacky that we're now giving more alcohol to make them better. But anyway, so it turns out that very dilute vinegar is fine.
Oh, all right.
Yeah. So 4% table vinegar is like 4 or 5%. We only need 2%. Well, actually 1% in mice and 2% in monkeys. So it's very benign.
Fascinating. And what journal is this going to be in?
It's actually out as a pre-publication.
Okay.
Yeah, Journal of Clinical Investigation. It's out. If you search it, you'll find it.
Okay, you'll have to put a link to that as well. That'd be great.
Yeah, it's a good journal.
Dr. Gittes, coming back to you, obviously you shared the Judah Folkman story at the beginning of the show. I'd like if you could take a little time. Obviously, you've throughout your amazing career, you've met many people in academia, in industry. Could you take a little time, other mentors, influencers, teachers, family members, whoever you want to mention at this point in the show, shout out people that have been really instrumental in Dr. George Gittes on this path, and if it wasn't for them, you'd be off practicing cardiology or something else.
Right. Well, I don't know about that. I mean, my father was a huge influence. He's the one who had me, doing portal cable shunts as a microsurgery in rats when I was 13. But that was obviously a big one, and as a role model. But then as I got into the pancreatic research, so after I finished medical school with Judah Folkman and became a surgeon interested in pediatric surgery because of him. But I went to University of California, San Francisco, was doing research there, and I had two really important mentors. One was the chairman of the department who took me under his wing. His name was Haile DeBass. He's an amazing African-American from Eritrea who went to Canada, was in McGill, and then moved to California, and was incredible gentleman and fantastic scientist. And he helped me, not directly in terms of what I was doing research-wise, but he connected me also to a friend of his who was a biochemist and the former chairman of the Department of Biochemistry at the University of California, San Francisco, named Bill Rutter. And Rutter was an amazingly accomplished individual who took me in his lab, put me under someone to show me how to do some of these, basic techniques like PCR and stuff like that back then was pretty new. And, it kind of launched me. But Rutter was a great inspiration. My first major publication was in Proceedings of the National Academy of Sciences, PNAS, good journal. And it was just the two of us were the authors, Gittes and Rutter. Pretty cool. But Bill, so he was a member of the National Academy of Sciences. He he senior authored a paper in 1982 that was for about 20 years was the most cited paper in the biomedical literature, because it was on how to purify RNA. Okay. And he was kind of an expert on RNA and figured all this stuff about gene expression. But then he cloned the insulin gene. It was the first gene to be cloned. That was his lab. Yeah. But, oh, by the way, and then he discovered the hepatitis B vaccine. And the guy was amazing. So he was a pretty good mentor. Not bad. Yeah. So I would say those four: Father, Folkman, and this guy Haile Dubas, and then Bill Rutter. I had a really cool experience in 2011 and 12. I think it was. I was asked to go back to the University of California, San Francisco, to be a visiting professor and give their talk. This lecture series that they actually developed when I was in training was named after one of their former chairs named Dunphy. So I came back to give the Dunphy lecture. And as I walk into the building, I look up and I say, oh, this is the William J. Rutter building that I'm going to give this talk in. It's pretty full circle right there. It's pretty cool.
Things come full circle. Exactly.
Yeah, exactly. So.
Well, Jordan, it's really been great hearing about everything you're doing, especially in this, as I said at the beginning, this major scourge of diabetes.
Yes.
And you're at the forefront of it, and really wishing you the best with all these projects moving forward. For everybody that's going to be watching this episode on the YouTube channel or listening on the podcast, you've been listening to Dr. George Gittes, Chief in the Division of Pediatric Surgery, Benjamin R. Fisher Chair in Pediatric Surgery, University of Pittsburgh Medical Center Children's Hospital. Also co-scientific director, Richard King Mellon Foundation Institute for Pediatric Research, director of surgical research, a professor of surgery and pediatrics, doing really amazing things to incubate and move forward research projects that shift the paradigm. George, it's been a pleasure listening to you, and really want to thank you for sharing your knowledge and everything you're going to be doing moving forward. As we say at the beginning, thank you for creating a better tomorrow for what's going to be happening. And it's been
hopefully,
a pleasure.
Okay, it's my pleasure. No, I always enjoy giving these kind of talks, because I think it's just good to get the information out there. And I know the diabetic community is potentially, cautiously optimistic that we're gonna move forward with this to clinical trials. So it's pretty likely.
Yeah. Well, thank you for doing it. And thank you for George.